itself is the problem with device selection, the size, design. So if you only have Watchman on hand, then you have this kind of different ways to overcome, and maybe to overcome the limitation if you really want to stick to a particular device. So I think your presentation is showing us how to tackle it with the limitation on hand without the choice of choosing another device. So how you do it? So is it the theme of your presentation? Yeah.
Simon,
yes.
may I come back to the indication?
Yeah.
The diameter of the left atrium was more than 6, right? Yeah. 6 centimeters. Would this be a contraindication for LAA closure? Because these patients had not been enrolled in any trial. There may be a risk of thrombus formation somewhere else in the big left atrium. What do you think? What do you do in your practice if you have such a patient, independent from the morphology of the appendage?
Yeah, so I would try to. I mean, the ostium is big, so the maximum.
No. I'm not talking about the left atrial appendage. I'm talking left atrium. Yes. Left atrium is so big that these type of patients never have been evaluated in any of the trials. So in all of the trials, left atrium size of more than 5 had been an exclusion criteria.
Yes. But then in a daily practice, we still do this kind of procedure. We don't strictly actually follow the protocols based on, for example, TOTAC, AF, and other ambulance.
I like that concept.
Yeah, so we have to create our own protocol.
There's no data,
yeah.
so we have to do it to collect data, right? Otherwise, we will change practice.
What's the potential cause of this patient huge left atrium? What could be? It is unusual in large left atrium. Is there any other cause? Like, is the mitral valve okay?
Let me see. Stroke, hypertension, and
that's not
long-standing.
We have quite a lot of these huge atrium cases,
especially
no good reason.
because we don't have very good ablation services in the past. So a lot of patients left like atrial fibrillation for 20 years, and
Yeah,
they
yeah.
have
It's
this
Patients
huge
with long-standing AF, it's not unusual to have large
mismatch.
One thing technically very challenging for big atrium is the sheath to get into the atrium, the appendage coaxially, because all the sheath, they have a pre-shaped curve, right? So that usually will expect the proximal curve to be landed as septum, but with huge atrium, this curve actually helps you bias to the upper part of the atrium, so it's very difficult to get coaxial alignment to the appendage. So sometimes you have to make a shaped curve just to help the sheath get easier access to the appendage.
I learned from hospital. I shaped every cases outside the patient and try to accommodate different anatomies. So this is what I learned. But I think, do you choose another puncture point or different strategy for patients with big atrium? Because the patient's big, the orientation, everything, access, sheath, everything. Do you have? Why would you change your approach?
I think in these cases you have to puncture low really, and also you have to prepare for double devices implantation for whatever combination you want. But most likely you probably need 2 punctures.
And also 2 venous punctures in case any device embolization we need to do something for backup. So I have 2 venous puncture over the colon should be considered. So
and also I think Randy is here for, I think we have to tell the audience lariat is really an option here. Although I would say it's quite big as well.
You can do it with the lariat. They have a 50 millimeter. I guess the question is, this is an advanced case. For people who are starting out, would you guys advocate even trying to do this? Or is this, or as YY was suggesting, do you pick a different device? Whether it's an AtriClip and or a lariat.
Well, maybe we can ask the audience. Let's take a vote. So for appendages like this, you would. So we have 3 options. One is just leave it, doing nothing, or maybe refer to surgeons. And secondly, we try some like surgical approach. So the first option would be surgical approach. Second is do nothing, just continue anticoagulation. Or 3, we try to do endovascularly. So who would choose to refer to surgeons or surgical approach? Raise up your hands.
Or a lariat.
Or lariat. Okay. And second, just do nothing. Okay.
I wonder what's the real reason to refrain from long-term oral anticoagulation. You just stated that he's not prone to do. What's his reason? He has a HASPAT score of 4. You said. What was he was bleeding recurrently under DOAC, or what was the real cause for not getting him on anticoagulants? Actually,
yes. Actually, I think most of the patients.
So it's the choice of the patient. Mm-hmm. Was the choice of the patient?
Yes, of course.
Okay.
Yeah.
I agree. Then.
Yeah.
So long-term oral anticoagulation therapy.
And finally, who would choose endovascular approach? So raise up your hand. Okay, it seems most of you are okay. So they are all cowboys. Okay, so how would you do then?
Okay,
so
show us how you did it.
So I think I would try to use a device to close it, but if I cannot, in my locality, I will use the AtriQ for this case. I don't have the lariat, but AtriQ is an option. So we'll leave it open. So this patient is not particularly very high risk in terms of AtriQ or other surgical minimum invasive closure of the appendage. But I will try my best to close it with a device first. I think I can close it with a device. So mainly is the approach. Maybe I have a CT. Maybe choose a device and appropriate for the anatomy. So it depends on the local experience of individual operator.
Yeah. So which device, Simon?
So I may choose that this type plus a low type device which have a flexibility and hope that this can have additional coverage, try to cover the second lobe as much as possible, but it's a try.
So maybe before that we discuss if you want to use devices, obviously one device is not good enough, so you probably need 2 devices. So you want to use what devices, and would you like to do like as stage procedures, or you want to do it at one time? So what are the reasons for that?
And also
address that.
What your decision making in terms of which device?
So my thinking initial thought is put, for example, if it's a luxury way to do it, I put a Watchman and then put another a Lamprey, for example, with a big disc to cover everything. So 2 Watchmen, okay, but they actually are irregular in shape. They may not be able to fill in all the gaps. And 2 this type device, they may interact with each other. So this is something in my mind at this point. So what do you think, Gary?
I think 2 Watchman device has certain limitation and potential problems because 2 Watchman will provide a figure of 8 for configuration. So there may be a lot of leak, PV device leak after putting 2 Watchman inside. And also the device to device, there are a lot of interactions. Therefore, there may be a chance of device embolization, even though there may be seems to be stable before the final release from the delivery cables. So the 2 Watchman is quite dangerous in my consideration. On the other hand, so for me, I would consider to use Lamprey, and as know that the current size of Lamprey may not accommodate for this kind of big orifice. But of course, in certain situations, maybe we can ask the company to tailor-make this very big device size of LAA. And in my center, we also have experience with YLM to cover this kind of very big LAA, which was also published 1 year ago. So I think LAMP should be considered to use in this situation.
Let me just make a point in terms of that. I agree with you that the ball-shaped devices like Watchman might create a figure of 8, but when they touch each other, when you go for a kissing procedure, they conform to each other, so they don't form a real 8 actually.
But you cannot predict, right? You cannot predict whether it really
right. But when you, I know YY did one case with Lambert with 2 devices. You cannot be sure that you also create new spaces when you use 2 lobe disc shaped systems, because you cannot make sure when you implant 2 sequential devices that one disc might stick out a little bit and you create another kind of neo left atrial appendage, you know.
But the problem is you cannot predict what is the interaction between the 2 devices inside. even before the final release. So I think I will stick to the one device.
Do you think like pre-procedural 3D printing and then you test it with various devices can actually help to improve your strategy?
Yes, I agree.
That's what we.
So actually, what measurement we got is actually from the fluoroscopy. So there are lots of overlapping. We know you never can get a very close look. Is it a single dimension?
Yeah.
Is it overlap shadow? Is it just a narrow entry? Then we branch out to look, but because of overlapping, they have this kind of appearance as very large. So I would agree, CT could help in this situation, and pre-testing, no matter it's a visual kind of assessment or 3D printing could help.
Okay.
Actually, I would prefer to start something simple first, try one device, but prepared if I want to put two, because the best thing is still to put one device, and two devices also not test in the clinical trials, so we don't know the behavior, but it works good for the cases serious, so I heard so far. So keep it simple first, and a better assessment for the true osteum, maybe with CT, before we start the planning.
I think the distribution of pectinate muscle also makes a difference in terms of device selection. Like in this case, clearly there's a big trunk of pectinate muscle separate the big appendage into two parts. So maybe kissing Watchman is a good idea. But if you without that big trunk of pectinate muscles, then you put two devices inside, then maybe I don't think about the anchoring mechanism. So maybe the stability would be a bit of concern. So maybe for interest of time, shall we see how they tackle this case?
Yes, certainly.